And I am just so excited to be here, and I want to thank all of the team from the nursing department for this incredible honor to get to be here. My husband, who is with me, a couple of decades ago, used to come to do a lot of work in Sweden, and I was always so jealous of him, of getting to come to such a wonderful country. And so I have been really delighted to get to come and to work with these colleagues. So thinking about how we can approach work as more than just 9 to 5, is more than just working around nursing. And the presentation we just heard, we were whispering together, Maria and I, how so many of the points that the professor made actually can apply to nursing. So I framed this time together to try to think about and look at the outcomes that we have from healthcare, and looking around the world, they are less than stellar outcomes for an area where so many countries, the amount of money spent on healthcare is not balanced with the outcomes that we get. So we're trying to change our approach in nursing education around how do we create and develop reflective practitioners, nurses who engage in their work, and as they go through the journey of nursing, of taking care of patients, developing and finding joy. Because the research that we have now actually links the way that you regard your work and look at your work, actually drives the outcomes of care. And that can make a difference to you if you are in the hospital. And probably this will disturb you just a little bit, but we were discussing airplanes just before we started, and everyone had an airplane story of being delayed. So actually though, and many of us are sort of white knuckle when the turbulence begins, but you're actually safer when you're in an airplane than you are in almost any hospital in the world, which is kind of a little bit of a disturbing thing, but we have learned so much from aviation safety about how we can change outcomes. The World Health Organization has really been quite responsive in helping to collect some of the information, and in fact, we can see that healthcare quality is at a global crisis when we look at patient safety outcomes. 1 in 10 patients has serious preventable harm. I'll use the word preventable harm. Sometimes you will hear that term as ERA, but preventable harm are those things that happen to a patient when they're in our care, and it's because of the things that we do, not because of the disease process itself. 160 million medication errors every year, and probably most of the audience here today, you're probably taking a medication at some point. And so thinking about how the problems in healthcare, if we use the same analogy with aviation, here are some of the headlines that we would see in the newspapers. There are 84 unsafe landings every day. Airplanes would be crashing every 3rd day. This is not anything that society would tolerate. Yet when we put the statistics that we have collected around patient safety into an analogous, and I don't know how we do this within an economic model, but we would really be able to see the depth of the problem and how preventable harm has now been labeled as the 3rd leading cause of death in the United States. So preventable harm, we've had lots of different estimates. And the truth is, the first estimate came out in around 1999, 44,000 to 98,000. 2013, the estimate was 400,000. And in the last one that we had published, 2016, 263,000 people. And this is just in the US. But the truth is, we don't actually know a number because death certificates don't list a cause of death, patient preventable harm. And so we have to extrapolate this from patient records to be able to come up with estimates. It leads us to ask the question, does the number matter? If it's more than 1 and it's your mother, your father, your brother, your sister, 1 is too many. And so how can we begin to look at these statistics, these huge numbers of patients who are losing their lives? How do we begin to put a face to this? And we use the story of Arlington National Cemetery in the U.S., which is where we are able to bury our military heroes. And this is just one hillside. And so over 150 years that we have had this cemetery, there are now just over 400,000 grave markers. And when you stand on that hillside and you just see all of these white markers, it's anonymous. But when you get up close, you see that each marker has a name and information about that person. And so it is with healthcare. We are trying to put the face on a preventable harm. And so the story of Louis Blackman that Maria used in the introduction has been a story that has been used and told, and we're doing some work here in Young Tripping around how we can put a face to ERA, to put a face to preventable harm, and to be able to change behaviors. So in all these years, more than 20 years that we have been looking at patient safety, looking at the data, and trying to think, what can we do to change? We have barely been able to move the needle on patient safety. And one reason is because it is so hard to be able to really put a parameter, to put a statistics. So we're looking at it then, how do we change this paradigm? And we're looking at, well, we need to change and create a new mental model of a healthcare professional. And so we look at it as education, as building that bridge across to quality, safe care, and how we need to be changing the way we prepare healthcare professionals, the expectations we have for them if we're going to be able to change the needle to be able to have different outcomes of care. When we look at patient safety, we can look at it from moral and ethical viewpoints. We can look at it from an economic workforce issue. And so when we began to break it down to look at the moral and ethical, we look at healthcare as a basic human right. And if we look at prevailing models, we see the drive to provide universal access, and someone referred to the Sustainable Development Goals earlier this morning. And so we can look at it from that standpoint of a moral and ethical. We can also look at moral and ethical viewpoints around how we provide work environments and the resources that we provide. So then we look at workforce issues, adequate staffing, human factors that come into play in patient safety. And what we have learned is that satisfaction increases when nurses are working in systems where quality and safety are valued. So work environment matters. Good working relationships also contribute to higher satisfaction and workforce retention. We have very clear data, and looking at the relationship that nurses have with their manager as being a critical indicator of whether they are satisfied, engaged in working, and whether they stay. So retention is part of that workforce issue. It costs in US dollars around $67,000 to orient a new nurse. So if you look at the fact that we have around 50% of new nurses who change jobs in the first year, we're spending an inordinate amount of money on orientation that could be redirected into changing the work environment and changing the resources that nurses have in order to do their work well. And we know that nurses want to do work well. They come into healthcare out of that moral and ethical perspective, but we have to give them the resources and help to develop the competency. So finding meaning in work comes from engaged, caring presence, and then gives the link to outcomes. We know some of this through some of the work of the Institute for Healthcare Improvement. Paul Batalden, who is a visiting professor here, helped to start the IHI several decades ago. And we had the triple aim for healthcare for many years. We're looking for better outcomes at lower costs and the improved patient experience. And this was changed just a few years ago to a quadruple aim for healthcare because of this research that links the clinician experience how it is that we relate within the system to better patient outcomes. So what we hear so much in the news, and it's making a lot of headlines in the US, is around terms that I see as very negative terms around burnout, around compassion fatigue. And so what this is saying to us is that working in organizations focused on quality, where you are reinforced for doing good work, can really change the way that we are able to link our work and see the joy and satisfaction. So instead of compassion fatigue, we experience compassion satisfaction, and therefore that eliminates some of the negative term around burnout. This does impact retention and helps us to move forward. So starting with the 1999 series of publications from the Institute of Medicine, we have the book To Err is Human. And actually, that is the basis when we are looking at safety science, that humans, we're human, we're going to make mistakes. How many of you have been you're a good driver, right? All of you are good drivers, yet you're backing out of your garage and you bump the mirror because you're distracted or you see something that moves your attention. And so humans are going to make mistakes. So we have to be able to change how we look at how we deliver health care and be able to change the traditional way of looking. This other book, Wall of Silence from Rosemary Gibson, began to draw our attention that we need new safety culture perspectives. Instead of treating errors and mistakes with a wall of silence, that we have to expose them and learn from them. So we look at it from a system perspective. The next book, Crossing the Quality Chasm, began to really lay out for us how we can look at safety culture from a system perspective. If you think of a hospital as interrelated parts, the different nursing units, the dietary, the x-ray, how do we create working relationships as a system perspective so that what we learn in one area we can apply? And so it takes it from the individual blame, which has been the traditional way of looking when we make a mistake in healthcare, to one where we expose it, where we are able to have a culture where it is safe to report near misses, where it is safe to report errors. And so then we can learn from those through analysis, things such as root cause analysis. We can trace back where were all of the decision points and where might we then change the process. We can use a well-known example, Dennis Quaid, the actor, his infant twins. One of them was given an adult dose of heparin. Heparin is a known high-risk drug, and so we have extra procedures for that administration. But when nurses are in a hurry and they don't have a good system to back them up, the nurse gave the adult dose to the infant. I can report there was a good outcome because they caught it quickly. But then we can trace back where were all of the decision points. So then we have different ways of storing the drug so that you are less likely, when you are harried and rushed for time, you're less likely to pick up the wrong vial. And these are tiny vials with very tiny writing. And so you can do things to change the color. So we have a lot of system redesign to try to be able to change the system. And so learning organizations are those organizations that it has a safety culture so that you are continually learning, continually trying to improve. We can look at the car and automobile industry. So I don't know if anybody recognizes this early version Volvo, but I love this picture of this car. It must have been really cool. And so we can look at what have we done in automobile safety from one car, the dark car to the light car. So you could think for yourself some things that we have done around having child locks so that children can't accidentally open car doors. We have seat belts, we have airbags, we have different kinds of bumpers. We can go through, and so How did we change the paradigm? How did we change the mental model? You would not buy a car that didn't have seat belts. You just wouldn't do it because we have data that backs it up. And I like to think maybe there was an ER nurse who noticed that patients who came in and it was reported they were ejected from the car had more serious injuries than if you stayed in the car. And so how do we collect this data and then begin to link it in a system perspective that we change the way we design cars to make them safer? We can do that same principle in healthcare. So we now look at safety as a science. We have been talking about safety since 1865 and Florence Nightingale in the Crimean War. But we have safety, we've learned so much that we look at it as a science and helping to become aware that everything I do has a risk. So how do we mitigate the risk, to lower the risk that we place patients in? So that means we use system alerts. We can use technology for working to find solutions to fix broken processes when patients have 14 different tubes and complex patients might have 14 tubes invading the body. How do you sort which one is IV, which one is for the nasogastric tube? And so it's that system you put in place to make sure you don't reconnect the wrong tubes. But the big difference is changing how we work with patients and their families to make them a part of healthcare, to replace the old paternalistic system that how we bring patients and families in as parts of the team. So James Reasons, who is a researcher from the UK, put it together with what we call the Swiss cheese model. And I thought about picking up slices of Swiss cheese from the buffet table this morning, but I decided to use something maybe more hygienic. So if you pick up a block of Swiss cheese, you know it has holes, but you can't see through them. And so the basis of Reason's model is that we have redundancies in the system to prevent mistakes from happening. Okay, let me use a very simple example. If you have recently been in the hospital, you've probably got really annoyed with nurses who keep coming in. What is your name? What is your date of birth? They look at your armband. They look at your bed label. Because we now require in the U.S. at least 4 identifiers before you give the medication. So that is so that we can make sure that we always have the right patient at the right time with the right intervention. And so what Reasons is saying is that sometimes we're in a hurry, sometimes things happen, and so 2 of those holes in the Swiss cheese line up. And then maybe a third thing. So we have redundancy in the system to try to keep mistakes from happening. And we have to have patients and families working together with us as patient safety allies so that the holes don't line up, but we catch errors before they happen. And so that is one of the ways that we are trying to change. But if you're going to be working that way, we have to change how we are conducting education to be able to help healthcare professionals to work from that perspective. So we try to identify high-risk situations. We call those red rules, things that you just never violate, like I'll go back to heparin. So one of the red rules is if you are giving heparin, you always you prepare it, but you have someone check what you're doing. Patient identification, timeout when you go to surgery before you start an operation to, again, is this the right patient? Are we operating on the right side? We still had 267 wrong site surgeries last year in the U.S. So there are things that we can do, but we build redundancies in the system. So we have to begin with individuals who make up the systems where we work. And so we have to pay attention to work culture, to the organizational culture. Safety culture is a subset of the overall culture, and culture is made up of our collective values, beliefs, attitudes, how we work together. So do we tolerate amongst each other that if you check heparin twice, it's okay, but if you don't, it's still okay? We have to have system reinforcement so that we will be consistent in behaviors and back each other up. And so it's how we respond to each other. It's how we include patients and families in care and be able to change the work environment. So I was part of a project in the U.S. that was called the Quality and Safety Education for Nursing Project, QSEN as an acronym. And this was a program funded by the Robert Wood Johnson Foundation to change fundamentally how we educate nurses. And we looked at, very often, safety and quality were like extra duties in the nursing work. We wanted to fundamentally change professional identity formation so that if we are thinking about what is a good nurse, what is an effective nurse, it is one who is conscious of safety and quality, who is reflective in approach, mindfully engaged, situationally aware, and follows the 6 competencies that we identified as essential if we're going to focus on quality and safety. And this work, by the way, has been translated into Swedish and adopted by the Swedish Nursing Society as part of the practice framework. And that's the genesis of being able to work together here at JU. So those 6 competencies: patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety and informatics. And as Maria said in her introduction, we have defined each of those in this QSEN project around knowledge, skills, and attitudes, which is how you develop a competency. What do I need to know? What do I need to be able to do? And what are the attitudes which shape? Now, we know we have content. We know what we need to do, and we have a lot of skills. But I tell you, trying to change attitudes, that is like pushing a bulldozer with your hands, trying to change attitudes. So I'm going to give just brief introductions to each of the 6 competencies and then talk about how we are using reflective practice to work around how we do that. So reflective practice is an inquiring strategy. Reflection is asking questions. So I've put this as in a series of questions for each of the competencies, and I'm probably not going to read but maybe 1 question per slide just in the interest of time, but just to help to illustrate how we are working with, for instance, patient-centered care is trying to think about how we get an accurate and personalized assessment of this patient's most important concerns. And this is something in the illustration that Maria used around Lewis Blackman of we gathered information, the nurses gathered information, but didn't really put it into perspective of that individual patient. So patient-centered care is really how we look at that individual patient. Teamwork and collaboration is how we have information. Nurses are the 24/7, but how do we teach nurses to speak up and share that information with other members of the team? Evidence-based practice. This is how we develop evidence through research to have best practices so that we know what are the ways that we can, for instance, insert a central line when you have open heart surgery, and we can make sure that you do not develop an infection. Quality improvement is measuring actual practice against a benchmark. So our benchmark is 0 harm. So then how do we measure various aspects of how we are giving care to be able to look at the outcomes of care? Informatics, how do we use information systems and technology, decision support tools? You may have seen your nurse walking around with this handheld device that has several textbooks of information in a little tiny handheld device to be able to look up when they're uncertain. And safety, how do we use the new safety science to reframe how we are looking at preventable harm? So this mindset, trying to change mindset so that nurses come out with the new attitudes around engaging in their work with the patient as the focus, encouraging inquiry, apply evidence-based standards and interventions, examine outcomes and critical incidents based on system thinking, and continually improving care. So we are trying to develop reflective practices. So sometimes we say reflective learning, reflective classrooms, reflective educators, but being able to engage and examine our work in a systematic way so that we look at experiences as a way to learn. And this really tied in directly with our previous speaker in talking about the interactivity and looking at the percentage of teacher talk versus the engagement and listening. So how can we develop professional maturity with mindful engagement, making sense of work experiences? Nurses' work is actually very dramatic, very complex work. And so being able to think in a systematic way and being able to examine experience, we expose contradictions, especially from the moral, ethical viewpoints, because we get in organizations that, well, don't walk the talk. They're not living according to their mission. And so we have dissonance and things don't make sense. So through reflection, we can ask questions about our work experiences. And one of the early writers in this area, John Dewey, said, we don't learn from experience. We learn from reflecting on experience. So if we just are working 9 to 5, doing our task, we may not be learning, but if we reflect on that in a systematic way, asking questions about what did I do? Why did I do it? What was the result? What's another way? And what else do I need to know? So self-reflection is only useful when it's followed by thoughtful action. And so we work with nurses around collecting this information, but then how do you share it? So this is labeled as the simplest experiential learning cycle around looking at the what, so what, now what model. If you use liberating structures, you may recognize this little set of activities. What happened? What were the results? How did I influence the outcome? What will I do differently next time? So having that as a habit of the mind, the mindset for nurses, for reflecting on, thinking about our work. So thinking about purpose. Why did we come to work today? What is our goal? What am I trying to accomplish with this patient? How do I care for self? It's like the airplane safety introduction. Put your own oxygen mask on before you help the person next to you. And so we are trying to also teach nurses that taking care of self is very important. So caring for self, caring for others. And in this way, we can begin to see the joy and meaning within the work that we do. It is work that makes a difference every day in the life of someone. So when we think about that and reflect on that, then we can move the needle, change and improve patient outcomes. So growing through reflection, caring work, working with meaning and purpose, engaged in doing work well, reflecting on it, asking questions for continuous improvement, and then experiencing compassion satisfaction to move to renewal. So let me ask you, what do you think this picture is? Anybody want to call out what you think this is? A window, a door? Okay. My favorite answer is a Hershey bar, a chocolate bar. Now you see it completely differently. But how many of you saw circles? Anybody find the circles? Let me see if this, okay, look right there. Okay, I didn't change the picture at all, but I redirected the question. And now you see something different in the picture. And now you can't look at that picture without also spotting circles. And so reflection, helping us to look at our work in a different way. So quality safe care is more than just applying knowledge. It's more than just content. It's more than just the skills, but it's how we approach our work. So reflection helps us to see what is just under the surface, so that when we look at a patient, we're seeing the person. We are uncovering and getting past our initial assumptions and seeing what we didn't see before. And I'm going to give just a quick reflection that one of our students wrote, and this student had been really fixated on technical aspects of nursing, and she was assigned to work with a patient who had 2nd and 3rd degree burns. I was assisting the burn nurse with changing the bandages and dressings and the removal of the staples that had been placed to adhere the artificial surface to his own flesh. It looked as though it was healing fairly well. At first, I was intrigued with the process that I was watching, and then I looked at the face of the patient. It was plain that this was the first time he had seen the extent of his injuries since he was admitted, and he was horrified. This experience was rich in caring moments for me as a nurse. It was an awakening for me to put the human context to the clinical conditions that I've only read about in books or simulated in nursing lab. This was not a limb with 2nd and 3rd degree burns to be debrided and bandaged. This was a person with a family to support and a crew of men who looked to him for their livelihood. This was a man used to being in charge of his environment and able to create things with the work of his hands, and now his life will be changed forever. So we can look at that and put it within an analysis of a reflective set of questions around what values and goals guided this young nurse in her observations and her interaction with this patient. What was the intention, and was that achieved? And what was the nurse thinking both during and after this situation took place? And so then what was learned, and what might this nurse take into the next thing? And while there are a lot of questions about this interaction from a deep nursing perspective, what we see is a transformation that as she reflected on this experience, that she went from thinking only about tasks to thinking about the whole person, the caring moment. And so this is the framework the JU nursing program uses also, a framework around caring and looking at the holistic perspective. So connection of staying close to our ideals contributes to job satisfaction. Clinicians who lose their values and ideals are going to burn out sooner. And so reflecting on practice to maintain focus, that is, to find joy in the journey around working more than just 9 to 5. So one last little illustration. A man was walking along and he saw 3 men working. And so he asked the first one, "What are you doing?" And the man said, "I'm laying brick." So he walked on to the second man. "What are you doing?" "I'm building a wall." He went to the third person. "What are you doing?" And the man said, "I'm building a cathedral." So when we think about healthcare, which caregiver do you want? One who's just laying brick, or do you want someone who sees the whole picture and is engaged with meaning and purpose and sees the whole picture of the goal of healthcare? And so how can we then think about that in terms of how we transform education and be able to transform outcomes, not just in one country, but from the global perspective of all? So thank you so much for the opportunity to share with you today.
Thank you so much. And no worries about time. I saw you looking at the watch.
Yes.
No problem at all. So again, we will open the floor to the questions from the audience. If anyone would have a question. If not, I will start at least.
Okay,
Because
all right.
Clearly, I have never worked in this sector. I know very little about it. It was a great presentation, but I can relate to this as a patient, I guess.
Yes.
So I'm thinking that given the worrying statistics you presented in the beginning, should I as a patient try to be more active in relation to healthcare, or would that sort of add to the stress they actually experience? And would I maybe be better off actually from staying out from the process.
Yeah, and it is somewhat frightening, but there are some things that, yes, that you can do. So one of the things that we are teaching people is when you are hospitalized overnight, have a patient advocate who might go with you, who might even stay the first night after surgery to help be an extra pair of eyes and hands. To also think about your health goals. And so when you are seeing your doctor, when you're in primary care or when you are hospitalized, that maybe you have keep a list of questions. And we are now, actually, I've just been a part of a national project around how to engage patients, and we developed a form. And so you give this to the patient to bring, and you fill out, what is the purpose of my visit today? What do I want to know? What is my health goal? And so you're able to share information. But another thing is really paying attention, and don't be afraid to ask questions. That yesterday you gave me a red pill and today it is a green pill. Why? Because maybe the order changed, but that's an opportunity for me as the nurse to teach you that. But maybe it didn't change and I've made a mistake, but you can make sure that I don't give you the wrong medication. So taking charge of your health care and being engaged and active in your care is one of the most important things that you can do.
Any other questions?
Do the nursing, I'm thinking about the reflection about the nurse taking care of the man with burns.
Yes.
So what do the nursing students usually say when they start to go from the task-focused job and to see the whole person? Is it like a new world opening up?
It is changing the focus that you still have the tasks to do, but instead of simply checking off the task, it's engaging in what you're doing. We have another example that we use in teaching. In many healthcare practices, for instance, if you've been hospitalized and you're discharged to home, and we know many mistakes happen in discharge planning. So there's a follow-up phone call 2 or 3 days later, and so the nurse calls. And we have an example where the nurse who's assigned to do the call, hello, Holly, how are you? And the patient says, I'm fine. You went home with 9 medications. Are you taking them all? And she said, well, I think so. My son filled all the prescriptions. No follow-up question. What about your renal dialysis? Are you scheduled for dialysis? And the patient, she says, well, I'm not actually sure. You'd have to ask my son. And the nurse simply says, okay, thank you, and hangs up. So she can check off, yes, she followed up with the phone call. Yes, she talked with the patient, but she had no prompts to ask, well, tell me which medications you're taking and when, and the actual specifics. And in this true story, 2 days later, the patient was admitted in a coma because she wasn't going to dialysis. She didn't understand even what dialysis was. So it's moving from just checking off that I made the phone call to engaging in follow-up prompts and finding out exactly what that patient is doing. So if you get a phone call following healthcare, you make sure, don't let them just do it as a task, but really engage in that phone call and give information. It's a good question. Thank you.
So is there, yes, one more question up here.
You know me, Gwen. I always
Hi.
have to say something. Just a reflection on what Maria said, and also to you, Gwen, is that since we have established more of the cues and focus and the reflection focus in the nursing program here in U, I actually met with a few students yesterday who are doing their 3rd semester, and they were going to educate me as a patient before I went home about my diabetes. And all of the groups started with the question, what is important for you?
That is such a terrific example.
And these are in the 3rd semester. So the cues and the focus on reflection do have huge impact.
Yes. And so that can completely change the conversation, because then you're beginning truly with the patient in mind. And so we talk about literacy and we talk about health literacy. And I can be a well-educated PhD with an honorary doctorate, but know nothing about my own health. And so we have to begin with that kind of question. That's a great storytelling.
Thank you. I'm up here, Gwen. Up here.
There, okay.
Yes, yeah. Just want to start to thank you for a great lecture. And about reflective practice,
yes.
From a nursing point of view, could you say something about barriers in different cultures? Because how allowed is it to perform reflective practice? Could it be more easy or difficult in different cultures? What is your experience of performing reflective practice?
Reflective practice as a nurse.
As a nurse.
Yes. That is a very interesting question. In the United Kingdom, nurses are actually through they don't say the Nurse Practice Act, but through the practice regulation, I think it's called, have 3 times a week that they have some minutes set aside for what they use reflective practice analogous with clinical supervision. Whereas in the U.S., the tendency is if I see someone sitting quietly, a nurse sitting quietly, I would say, why are you not up doing something? That the tendency would be for the why are you not up doing something? So we have this real tension between doing and being. And so there is a tension there, and it is not always appreciated. This is why we have to change the culture. Safety culture demands that we think about work and think about how are we putting systems in place so that we make sure right patient, right time, right intervention. But also appreciate that there are many forms of reflection as briefing, so that everybody is planning and on the same page. Reflection as problem solving, reflection in action where we huddle and problem solve, stop the line when unsafe things are happening, and reflection on action, the debriefing that occurs. And so we find that sometimes by using reflection before action, in action, and on action, planning, huddling, and debriefing, we can use terms that make it a more quote-unquote acceptable form of activity to shift the mind from just so task-focused to recognizing that we do need those times. So here's one example of how we are trying to change at UNC hospitals. So now when a patient codes, that's when someone's heart stops beating, and you call this big, what do you call it in Sweden, when you have a response to a code, and a code team comes and they pound on your heart and do all these things. I don't know the Swedish term for this, but when it ends, then they gather in the hall for 5 minutes. What went well? What didn't go so well? And what will we do differently next time? And so I've been talking with the nurses. How does this make you feel when the physician calls for this debriefing? And it's like, now we feel a part of the team. And we really are doing the work differently next time because we learn from each other. And so having that opportunity from something that's such a critical action can begin to change the mindset and the perspective. It may even be that as I'm entering a patient's room, there's a nanosecond when I think, who is this patient and why am I entering this room? Rather than just the light is on and our standard of care is the light can't stay on more than 5 seconds or I get dinged in my performance review. So it's thinking about sometimes in very quick ways, and sometimes it's in more sustained ways.
Okay, so with that, I would say I hope you brought more than one suitcase, because we have a few things here, and not only the fantastic hoodie
Oh,
and the boxes,
thank you.
but I also know that Maria Björk will have another gift for you.
Oh my goodness.
We want to thank you for sharing your knowledge concerning the core competencies and the reflective practice. And I have to put it.
This is why my husband came with me to carry the luggage home.
Yes, exactly.
How beautiful.
So we are so glad that you share your knowledge to us. And this is an apple of knowledge
Thank you.
from Glenna that we want to give you. So
thank
thank
you.
you.
Yes. Thank you, Annette, for taking me to Glenna.
So thank you very much.
Thank you. Thank you.